So we've still got folk joining, but just to say welcome. My name's Mark Rowland. I'm the Chief Executive of the Mental Health Foundation and proud to be co-chair of the Mental Health and Smoking Partnership. I've been doing this for 3 or 4 years, and we have Ed Beveridge, who is the presidential lead for physical health at the Royal College of Psychiatrists, who's joined me as co-chair in the last couple of weeks or a couple of months. So Ed, if you're on the call, welcome. The purpose of the Mental Health and Smoking Partnership is coordinated and hosted by ASH. But our central passion is to make sure that in this effort around tobacco control, that we don't leave behind people with mental health conditions, people struggling with their mental health, and the aspiration of a smoke-free generation won't be achieved unless we bring those with mental health conditions who have much higher rates of smoking than the general population with us, and looking at how we can reach this population with effective evidence-based smoking cessation services. So this is a great social goal that we've got. It's tangible. And today we want to bring people together. It's really looking at the launch with ASH. We've launched a new report. It's called Closing the Gap: Stop Smoking Support for People with Common Mental Health Problems. And we really want to focus on that population, about 1.5 million people in the UK with anxiety and depression who are smoking, and their smoking rates are about almost double that of the general population. So we want to come together, look at this population. How can we drive change? Thank you so much for making some time for us. We've got an hour and a half all together. You will have the chance to ask questions, put them in the chat. We'll collate them and hopefully have some Q&A. We've got a fantastic list of speakers here who are going to run through the findings of the report and different aspects and case studies and examples of positive practice and the challenges. So you're going to get value for money, folks. It's going to be a great session. And just ask to do put comments in the chat and your questions, and we'll come to that. I just wanted to start by saying a couple of things. It's a good time for both tobacco control policy and mental health policy. All right, this is a good window for us. We celebrated yesterday the 50 years of the all-party parliamentary group on tobacco control. 50 years. Congratulations for those who have flown the flag to take on the tobacco industry and its health harms for 50 years. Fantastic. And we've got this, historic tobacco and vapes bill passed earlier this year and given royal assent. And as I said, it's just our passion is to make sure that we don't think the job is done, and that we have a real focus on addressing smoking within populations that are at higher risk, particularly those with mental health problems. On the mental health side, a couple of weeks ago, I had the privilege of having the Mental Health Minister, Gillian Merran, come to our offices and launch a cross-government mental health plan, which the government wasn't and hadn't been committing to, something we'd been pushing for many years. And in that cross-government, that consultation opens, and it will open until the 10th of July. In that request and consultation brief, they are looking for tangible evidence-based ways to improve services for people with mental health problems and focus on prevention. This is an opportunity for us to take what you hear today and help shape that agenda. We've got the Modern Service Framework, which is looking at clinical standards for people in secondary mental health care, and we've been engaging with them. And I think this report has lots to feed into that work. And then I also sit on the independent review around the prevalence of poor mental health, and that's going to be reporting later this month as well about the rising rates of mental health disorders and ADHD and autism. And the thing that we are seeing, and that the reason this report is timely, is that we've got landmark legislation on tobacco control, but we've also got rising prevalence rates of people experiencing poor mental health. The Mental Health Foundation will produce a report next month looking at, since 2009, the trends around poor mental health, and we're going to estimate that since 2009 an additional 5 million people are living with poor mental health. And given the risks that those people, we've got to do everything we can to support those who are smoking to quit smoke and prevent people rising numbers of young people who are struggling with their mental health turning to tobacco as an option to cope with, as a coping mechanism. So it's really timely. I want to thank ASH and specifically Rachel Maynard, who has delivered this report and written it, and we want to get into it. So I will hand over to the speakers in a minute. We're going to look at all of the inequalities around smoking, some practical examples, and what action we can take. So be prepared to listen, engage, but also take away what can you do in your role to progress this agenda. That is really the purpose of this session. We are going to record the session, so it's going to be available on the ASH website after this webinar, and there will be a Q&A at the end, as I said. So you can't come off mute apparently, so you can't speak, but you can write. So that's going to so we really encourage you to do that. Okay, I won't take up more time other than just to introduce our first and eminent speaker, Dr. Debbie Robson, who's been a leader in tobacco harm reduction for many years and is at King's College London. Debbie's a reader in tobacco harm control at KCL and theme lead for public health and multimorbidity at the NIHR Applied Research Collaboration in South London. She's a fantastic speaker and is going to just provide an overview of smoking and mental health inequalities. What's the scale of the problem and what's the scale of the prize if we get this right, and the challenges of reaching those populations. So with no further ado, Debbie, I'm going to hand over to you.
Thanks, Mark, and good morning, everybody. So Mark's done a great introduction, so next slide, please, Rachel. So in terms of the scale of the problem, it's quite huge. So the latest adult psychiatric morbidity survey for 2022-24 estimate that between around 17 to 20% of people in England have symptoms of a common mental health condition. And by common mental health condition, we mean depression, anxiety, and anxiety-related disorders. And more women have symptoms of a common mental health problem than men. And younger people, compared with older people, have more common mental health problems. Next slide, please, Rachel. Next slide. And as Mark said, mental health problems are on the increase. They're not coming down at all. They'll continue to increase. And common mental health conditions, they're more common amongst people who live in more deprived areas, are in problem debt, or unemployed, and economically active. But so is smoking. Smoking is more common and clusters amongst these issues. And ASH estimate that there are around 1.5 million people with depression and anxiety who smoke. And we know from some of our own research at King's, using the smoking toolkit study with colleagues at UCL, that smoking prevalence rises quite sharply with comorbidity. So these figures match the work that ASH did to support the data in this current report. But the more mental health conditions you have, the more comorbidity, the more likely you are to smoke. Next slide, please. And from other work we've done, we know that people with mental health conditions, they're more dependent on smoking. And they're probably, although there's less evidence of this, they're probably more dependent on vaping. But despite this level of dependence, they're more motivated to quit smoking, and they might make more quit attempts than people without mental health conditions. But those quit attempts are less likely to succeed. Next slide, please. And there's lots of reasons for this. There's kind of obvious reasons that kind of we know about, but there's lots of invisible challenges to having a mental health condition. And for many people, smoking is not the only problem on the table. It's just one of many. So people are kind of, you know, as well as kind of the mental health symptoms, they're all also potentially struggling with kind of financial problems, caring responsibilities, insecure work, loneliness, trauma, and exhaustion. And each one of those things takes up lots of energy, and it kind of reduces one's reserve capacity to be able to deal with something else. And even helpful offers can feel like demands. So a referral to a stop smoking service, it's another appointment. A quit plan it's another task, and a missed call from your advisor is another small failure in your life. And a relapse back to smoking, it's just another source of shame for you. But also importantly, and something that ASH has, since the Mental Health and Smoking Partnership kind of was set up, ASH have been talking about the lack of data in this population about tobacco smoking prevalence. And the latest adult psychiatric morbidity survey hasn't released their tobacco data yet. They've released all the stats on every common mental health condition, every serious mental health condition. They've talked about alcohol use and illicit substance use, but they've not released their tobacco data yet. And we also see these people missing from our other national data sets, like the Office of National Statistics, and it's not just people with mental health problems, it's other people in health inclusion groups. And colleagues at UCL have estimated that about 1 million smokers are missing, largely from health inclusion groups, are missing from our national data. And so if they're hidden in our surveys, they become hidden in the evidence base that drives our policy and treatment guidelines. And one could argue that we've built the evidence base on smoking cessation, and we've built our services on the backs of people that are easy to study, who are easy to engage in services, and who are easily seen. And also, when everybody is submitting their quarterly returns that get sent up to NHS England around who is setting a quit date and who is successfully quitting, we don't know how many people with a mental health diagnosis are setting a quit date or successfully quitting, because we're collecting that information locally, but we're not collecting it nationally. And so all that data, some of it's missing, but some of it is just in silos at the moment. Next slide, please, Rachel. So some research that we've done recently that some of you might have participated in. So we were commissioned by the Department of Health and Social Services, Social Care, to evaluate the extra £70 million a year that were going into local stop smoking services. And we surveyed 272 stop smoking practitioners from 120 local authorities, and 62% of them said they were working with people with common mental health conditions, and 47% said they were working with people with serious mental illness. And in terms of what they were supporting these groups with, so the majority were getting a combination NRT or single NRT or e-cigarettes. But when it comes to other evidence-based medicines like varenicline, then you can see quite a big dip, particularly with those with severe mental illness compared to common mental health conditions. We're not seeing a lot of cytosine used, and we're not seeing a lot of bupropion used. In terms of behavioural support, the majority of people were delivering one-to-one in-person support, which is good to see. But we're not using digital interventions very much with this population. And then when we get to other types of behavioural support like Alan Carr, that drops even further. Next slide, Rachel. So finally, just to kind of sum things up, and before we kind of hand over to Rachel to talk us through the reports, people with common mental health conditions, they're more likely to smoke, more dependent, make more quit attempts, but are probably less well served by standard models of support. We know that they want to quit, and we need to turn this motivation into quit attempts, and we need to turn those quit attempts into quit success. And we really need to find new and better ways to do this in a way that feels relevant and achievable for people, rather than just another burden or a source of shame when things don't go particularly well. So falling through the cracks, as usual, Ash always come up with great titles for the reports. And I'm going to hand you over to Rachel to tell you about the report. Thank you very much.
Thank you, Debbie. That's a really fantastic canter through the evidence. And I think what really stuck out for me is, I mean, the whole history of people with psychiatric diagnoses is that they have been shamed and often invisible. And so this is a population that doesn't need to be, we know who they are, and to not have their smoking status and to not know how they are, those two issues are connecting is a real failure in the system. So thank you for highlighting both the importance of a shame-free access to smoking cessation, but also the importance of visibility for this group. I also sit on the National Suicide Prevention Strategy Group, and it's really clear that one of the things it struggles with is where to focus energy and time, and this is a population with high need, high risk, and we know where and who they are. So really there is no excuse for not having a really targeted approach. So Rachel is the Senior Policy Officer at ASH, Rachel Maynard, and has led the Closing the Gap report. Rachel, do you just want to come on and just set out the report's key findings and some of the recommendations as well that you're setting out for national governments, for local authorities, and also for the voluntary sector? Rachel.
Yeah, absolutely. Thanks, Mark, and thanks so much, Debbie. So yeah, I will do a bit of a kind of whistle-stop tour of key findings and recommendations from this new report. But first, just to say kind of why this report and why now. So we wanted to develop this because while there has been progress on implementing smoking cessation support in inpatient mental health settings, there is this much larger group of people with common mental health conditions who may never come into contact with this support, where the focus of recent mental health tobacco dependency work has kind of been happening. But as we've heard, this group continues to face significantly higher levels of smoking prevalence. So this kind of raises the question of, are we doing enough to support this group? So what we wanted to do with this report was kind of outline the current landscape of stop smoking support for this group of people, identify the gaps in services, policy and data, explore examples of promising practice, and then develop recommendations for national government, the NHS, local authorities, and the voluntary sector to kind of hopefully start bringing all of this into one place. Because ultimately this is a huge population of people, so a massive opportunity to accelerate declines in smoking and improve population mental health if we can support this group to quit. And just in terms of input for the report, so we held roundtable discussions with local authorities, people from NHS services, academia and the voluntary sector. We also had input from those with lived experience. We drew on our local authority stop smoking services survey, and we also had input from those in our mental health and smoking partnership. So yeah, thank you so much to everyone that contributed so that we could bring all of this together in one place. And just in terms of the kind of very top level key findings, so what we have found is that around 1.5 million people in Britain with depression and anxiety are smoking. Currently, support remains very inconsistent, but the whole picture isn't one of failure. We also found really excellent examples of local authorities, regional alliances, voluntary organisations, all developing innovative approaches that were really successfully targeting this population. And the challenge is more that these approaches remain uneven. At the moment, it's dependent on local leadership, and they're not reaching everyone who could benefit. So national leadership and coordination are desperately needed to kind of start building on this. So in terms of recommendations for national government, as I've just mentioned, a major theme throughout the report was the need for stronger national leadership. At the moment, there is no national target for reducing smoking among people with mental health conditions and no strategy for addressing these inequalities. So a really key recommendation is that we're calling on the government to publish a roadmap to a smoke-free country, which prioritises people with mental health conditions. We are also recommending the development of a national toolkit to support more consistent practice across all sectors. We're recommending the funding of the wider rollout of stop smoking support in NHS Talking therapies. These services supported over 1.2 million people in 2024, so it's a huge opportunity here to embed support into existing mental health services accessed by those people with common mental health conditions. And also to improve the understanding of smoking and mental health through communications. And then in terms of the NHS recommendations, so a really key one, and this was touched on by Debbie as well, is that reinstating the data collection on smoking among people with common mental health conditions is going to be really important. So we know that the GP patient survey, for example, used to report on this, but hasn't since 2017. Since then has reported on those with long-term mental health conditions kind of all pulled together. So it's not entirely clear kind of what we're dealing with. And without good data, it becomes much harder to kind of understand need, monitor progress, and set meaningful targets. So that would be a really helpful kind of starting point. And then secondly, again, to integrate stop smoking support into talking therapies. And Gemma will speak to kind of some of the evidence around embedding this support a bit later as well. In terms of recommendations for local authorities, so one of the strongest themes in the report was that local authorities are really uniquely positioned to coordinate a whole system approach to tackling smoking in this group. And this goes beyond commissioning a stop smoking service to developing a comprehensive local strategy with clear targets and accountability, building partnerships with the NHS, mental health, voluntary and community organisations, but also other organisations that support groups of people with typically higher smoking rates and poor mental health, because we know that this group isn't necessarily going to be accessing any mental health support at all. So we need to be able to provide that support to them where they are getting it in their community anyway. It also means developing more flexible and tailored support. And we also saw some really strong examples of comms campaigns that were helping to raise awareness of the links between smoking and mental health, which we'll hear more about later. But that is really important because we know that both the public and in professional settings, there is a bit of a gap in understanding about the bidirectional relationship between the two. So that is really important as well. And finally, recommendations for the third sector. So we know that this sector is also really well placed to support this work. Mental health charities, for example, are among the largest providers of commissioned mental health services, including that of NHS Talking therapies. So embedding stop smoking support within these services represents a significant opportunity to reach people that might not otherwise be engaging with traditional services. The same is true again for other voluntary organisations working with populations that experience both high smoking rates and poorer mental health. But that is going to mean upskilling staff to deliver advice and referrals, and also adopting smoke-free policies that support staff and service users. So what should we be aiming for? So we should be aiming for the 1.5 million smokers with common mental health conditions in Great Britain to be supported to quit smoking. People with poor mental health should be able to easily access tailored stop smoking support within their communities. Local authorities should lead a whole system response to smoking, bringing together local services. Smoking station should be routinely embedded within mental health and community settings. And finally, having that national data targets and framework put in place is just incredibly important to be able to drive accountability and improvement. So yeah, that is everything from me. Thank you. I will pass back over to Mark.
Yeah, fantastic outline, and we've got the resources there, and it'd be great if we could put the link to the report in the chat as well, so that people can have a look through after the meeting. But excellent, Rachel, and really clear. Do do encourage you to put your comments and questions in the chat. How do those recommendations land for you? What do you think would work? Where do you think the focus should be? What should we prioritize? What do you think the challenges would be? So do put your comments in the chat. And as I said before, I think with a new cross-government mental health plan, looking at the areas outside of mental health services, looking at wider influences on mental health, this report recommendations I think is going to be really timely, Rachel, and really important for us to get some traction on. I think one of the myths that is still persistent is that smoking somehow relieves the symptoms of poor mental health. And I want to bring it in Sarah Milne from who leads the South East Smokefree Alliance, because some of your work on this has been really important to really highlight how much quitting smoking can actually benefit your mental health. And I think some of the emerging evidence that Debbie and others have shown is that it's not just that smoking exacerbates poor mental health, but can also be a causal factor for those who have never experienced poor mental health. So it's terrible for physical health, but also for mental health. So Sarah, come in and tell us your experience and the campaigns that you've led.
Thank you. So the South East Smokefree Alliance is quite new amongst the regional alliances. We've been going for just over a year, and I've been my role as lead is just over a year old. And I come from a health psychology background, so for me, the sort of mental health element was key right from the start. So we were considering what we were going to do for our first big regional campaign. And we decided to look at this very link between smoking and mental health, and to focus really on the common mental health, because obviously a big regional campaign is about breadth and across the regional footprint, and so that seemed to be a really good group to target. So can we have the next slide, please? So we worked with Eskimo Soup, that have worked with I think the Yorkshire and Humber region before. So to begin with, they were doing our PR, but then we were talking to them about the sorts of campaign we were looking at, and they had done a small campaign for a local authority on smoking and mental health. So we developed the campaign they'd already got, and we were working with partners right from the start. So we worked with people in mental health teams, with all our local stop smoking services. We now have all 18 local authorities in the South East as part of the Alliance, and this campaign was the first time we had everybody involved. So we're working with all the different local authorities, with mental health experts through these different authorities, and Gemma Taylor, University of Bristol as well, to do a really good evaluation of this, and as well as some Information by Design, who are a data collection company. So we had a range of assets, and if you click on that link there, that will take us to our TV ad, which we can play, hopefully. So that, if you scroll down, there is the TV ad there. So I don't think we've got sound at the minute.
I wonder if can you hear it now?
I think you have to share with sound. As you share the slides, you have to share with sound at the start. So it might be that we can't get this now if we haven't got sound. But if you go to our website, which is quittogetherlivebetter.com, you can see this T advert. I mean, you could play it, but you won't be able to hear what it's saying.
How long is it? How long is it, Sarah?
It's very short. It's a couple of minutes.
Yeah,
Well, it's not even a couple. It's 30 seconds, under a minute.
Let's play it.
Yeah. So there is a voiceover explaining what's happening in the brain as we smoke, and saying that it's talking about how smoking robs us of our own dopamine. So this is the dark bit there, but the fact is that it says our something like our magical brain or our wonderful brain can within weeks can fix its own dopamine and make dopamine for itself. So it's talking about what smoking does with dopamine. We've also got another video actually on our website under campaigns, which shows it was a longer one. It was about 2 minutes, and we used that for partners to explain to our partners exactly what is happening with the brain. So it was unpacking these different neurotransmitter impact that smoking has on the brain and what happens when you quit smoking. So because we really wanted our partners to understand what smoking does to the brain and what quitting smoking does to the brain. And we are in the process at the minute of remaking that longer video into a sort of more user-friendly language for people that don't understand all these different neurotransmitters, so we can use it with the public as well. So we had a range of assets that included leaflets that had the 4 steps to what happens when we smoke, what happens with dopamine, and what happens when we quit. We had all sorts of, as you can see here, we had a radio advert, which is basically that TV advert voiceover. We had Spotify, we had GP surgery, so we had different slide decks for GP surgeries and all sorts of, like you can see all these different places. We had our campaign, and that took quite a lot of work with partners on the regional level. We had webinars in each local area so that people could be introduced to the different assets we had and how they could use them. And as you can see, it was quite even. It wasn't just one thing. It wasn't just the TV. It wasn't just the Google and Facebook. There was quite a lot of different channels that contributed. So this multi-channel, so people are seeing this message in various different places. They're seeing it on television, then they're seeing it in their GP. It was played in psychiatric hospitals as well. We did a roadshow, which I'll come to. So I went to every single area in the local in our region, and we did a roadshow. So we spoke to people directly. The train aspect you see there, saying 6% said they saw it on a train. We didn't have any train ads. That was me with my big sandwich board, which you'll see in a minute. The pub, that would have been, we had beer mats, which we also used as coasters. There was all sorts of things. So if we go to the next slide, please. This is our roadshow, and this is this roadshow. We had people came. This lady here, she came all the way because she'd seen it, she'd heard about it on our local radio, and so she came all the way to visit the roadshow in the pouring rain because she wanted to quit smoking, which was really cool. So overall, an estimated 193,527 people who smoke, actually, not just people who smoke in our southeast saw the campaign. And of those people, an estimated 73,923 said they were going to try and quit. So they said in the South report at time 2, after the campaign, they said that they had either started a quit date, or they were they'd either set a quit date, or they were going to make a quit attempt, which is incredible. Really, really successful. We actually checked that data about 3 or 4 times, and we went back to our data collector team and just said, can you just check that again, because that just seems amazing. So if we go to the next slide, please. This is the roadshow. So these are people that we actually measured as we spoke to them. Now, we made all the people in this, the 604, these are people that we know had the full kind of, this is what smoking does to your brain, this is what quitting smoking does to your brain. We know that these people had that message, so we didn't only counted those that had that message. If they had just come along and just had a quick kind of I want to quit, or they hadn't stayed long enough to receive the message, we didn't count them in. So out of those people, 311, so 51%, made a change in behaviour from contemplation to action. 28%, so 152 of those people signed up immediately at the roadshow with their local stop smoking service, because this was in partnership with local stop smoking services. And 22%, we said set a quit date after very brief advice. So they were people that said, look, hey, yeah, I'm going to set a quit date. And we'd say to them, okay, research shows if you set a quit date, you're more likely to succeed. So we asked them, what is your quit date then? And they gave us their quit date, but they didn't want to come into stop smoking services at that time, but they were given information to say, look, you know, if you find that you're not successful and you need more support, please do contact your services. A further 40% changed their attitude and strengthened their motivation to quit and went from pre-contemplation to contemplation. Only 9% said they expressed no desire to quit and wanted to quit smoking, which is incredible. We ended up in what was really most effective was going up to people who are smoking at the time, lighting up a cigarette. We were walking around the local areas of where our roadshow was, and just going up to people saying, hey, if you're smoking, look, did you realise, can we just tell you something? And people were like, no, I don't want to hear what you've got to say. And then we were saying, can I just tell you one thing that you might not have been told before, and that is that your brain's lying to you. When it thinks that it's helping your stress, it's actually lying to you. It doesn't, it makes stress worse. And we explained how and why. And we did have a significant number of people saying, okay, do you know what, take my phone number, get this local stop smoking service to contact me, you're right, it's not helping my stress. And even those that didn't want to quit, they said, but do you know what, thank you for telling me that. That's something new, I will think about it. Only 4 people in all of those people, so only that number 4 in the 600s told us to do one. It was, most people said, I don't want to quit, but thank you for caring, if they didn't want to quit at the time. But as you can see, it was a huge impact on behaviour change. So we really want to do more of this, engaging with people that are smoking, and we're working out how we can do that across the regional footprint. So next slide, please. This gives you what the actions that people said. This is all our participants, so this is all the people that smoke. You can see that the breakdown there. This is what people have said they had done, having seen the campaign. So 20% said they spoke to a GP or health professional, 17% said they visited our campaign website, 14% said they had set a quit date, another 14 said they'd look for quit support. And you can go down, 9% said they'd called a quit line or had contacted their local stop smoking services. And of those, 5% said they had referred themselves to a local stop smoking service. And that's really cool, because of course we know that 5% is our target for stop smoking services. And we also know that we can't have every single person in the southeast who wants to quit smoking go through our services, or they'll be overrun. So the fact that we have had 74,000 quits, including a lot of self quits, is really exciting. We know that not all of those would have been successful, so we know that we need to do more now through the year to have some campaigns around the important trying again. And we have the next slide, please. And this shows the difference of those actions if they had seen the campaign or if they had not seen the campaign. So you see the yellow, these are people that were aware of our campaign, and the orange here are those that are not aware of the campaign. And in those different actions or planned actions, you can see there's such a big difference. So the campaign was really successful, and we are going to be running this campaign again this year. But we've also got some ways we're developing it. So next slide, please.
Just one more minute. Thank you, Sarah.
Okay, so what we're doing now is we are doing more work to train people about our partners around this relation between smoking and mental health. Next, and we also are working with Gemma Taylor on embedding stop smoking services in talking, therapies and counselling, and we're developing specific toolkits for partners that work with different in different settings with people with mental health. Next slide, please. Being quick now to get through this. Our first toolkit is for Pride Month, which we're using this month and also right through to August, because Pride's are taking place in the southeast across those 3 months, and we know that there's a big link between mental health and smoking and Pride, so we have our Pride toolkit. Next slide, please. And we're also doing some research with all these partners that you see there. I'm being ultra quick, and I would like to just sort of plug, we are doing some work around ADHD, developing a specific smoking cessation intervention. That's with, again, University of Bristol and NCSET. So if anyone is interested in getting involved in that, please do get in touch, because we are looking for recruiting people who have ADHD into a really exciting, quite groundbreaking piece of research using apps. And it includes cognitive tasks, so we can see exactly what's happening in the brain with and without or brain function with and without nicotine. So if you're interested in partnering with us, please get in touch. So thank you. Yeah,
that's wonderful. Really inspiring. I'm sure there's going to be questions and comments on that presentation. So thank you very much, Sarah, and fantastic to see the passion and energy in reaching people who are smoking and perhaps haven't recognised, I'm sure, the link between smoking and mental health. So let's stay with local authorities or the local picture and come to Sarah Hepworth, who's the Associate Director for in South Yorkshire for Tobacco Control Alliance. And Sarah, just come and talk to us about the work that you're doing and the Alliance and the sort of population level campaigns that you're running, and particularly focusing on people with mental health problems. So Sarah, give us the picture from where you are in South Yorkshire.
Fabulous, thanks Mark. So I'm here today with two hats on. Firstly, as the ex-tobacco control lead for Sheffield for 12 years, I'm going to talk about our experience of implementing effective new service in terms of addressing priority groups. And then secondly, I'm going to talk about the regional comms campaign that we developed across South Yorkshire. Next slide, please. So I'm taking you back to March 2022. I was coming out of COVID response in Sheffield, and I was tendering the new stop smoking service. And this was at a point where the 5-year contract was ending. So it was a real opportunity to review and refresh. There was a lot to be proud of in Sheffield at the time. We've reduced smoking in prevalence by 30%. We'd gone from 17.6% to 10.3% between 2017 and 2022. We have the third best smoking prevalence in Yorkshire and Humber and the lowest of the core cities. And we're one of the most proactive tobacco control programmes in the country. We won the Local Government Chronicle Award in 2023 for our tobacco control programme. Next slide, please. However, the job was not done, as it still isn't done. We'd got 53,000 smokers that were continuing to smoke. And like others in the country, we continue to see stark inequalities between those who continued to smoke and those who didn't. And we saw significantly higher smoking rates with people who lived in social housing, people who lived in our deprived communities, and people with serious mental health problems, but also with anxiety and depression. And we knew by this that in order to achieve the government 2030 target, we would need 26,500 people to make a quit attempt every year. So that obviously needed a population level approach across the system. It was a huge challenge. It was also getting harder to reach more complex, heavily dependent smokers with multiple needs, and we needed to work differently. The service as it wasn't fit for purpose. Next slide, please. At this point, the ICB had given me, they'd agreed to £598,000 a year investment in the stop smoking service. That added to the investment I'd got at the local authority meant we'd have over 1.1 million. This was fantastic news. This was before the government funding came in, and it meant that I would double the capacity of the service. But what I was really concerned about, you remember in 2022 that we were coming into the cost of living crisis that's still in play today. We'd also got people coming out of COVID and the impact of COVID. So it was really important that my service was really attractive to our priority groups, and particularly to people with mental health conditions. So I wanted to look at the enablers and barriers around why people stop smoking and access stop smoking support. So I partnered with Sheffield Hallam University and the Centre for Behavioural Science and Applied Psychology, and we did in-depth interviews with 28 people from our priority groups, of which there were a number from people with a lived experience around mental health and smoking. I haven't included all the stats here for brevity, but if people do want the report, I'm happy to share. Next slide, please. Oh, it's all coming. It's changed the colours of it. Okay, so in terms of the key barriers and facilitators, what we found was that people felt that due to living under circumstances of stress, that they would delay the reasons for quitting, that they believed that smoking was a protective factor, as we've heard already, that it helped them cope with stress. They believed that quitting would increase their stress, that actually it would make things more difficult because of what they were dealing with and the cost of living crisis. We heard things like, I don't have a stairs carpet, it's really difficult for me to get to quit smoking, it would just increase, it would be something else for me to do. They experienced stress also from previous quit attempts. They felt that the fear of failure impacted on them negatively, and they were worried that it would impact on their mood and they would regret going back to smoking. And there was a lack of belief in their capability to achieve and quit smoking. Next slide, please. Okay, in terms of what people told us would support them increasing uptake for the stop smoking service, what I'm going to talk you through here wasn't new news to us, but what was really interesting is that a lot of this we already had in play around communication and education. Our information through comms and marketing campaigns or service leaflets told people about what the service did, but it was clear that we weren't reaching people as effectively as we thought. So we needed to tell people about the benefits, where and when and how they could access the service, ensure we'd got accessible information in different formats. We weren't great at having translated materials across the board, and we also weren't great at accessible information in terms of easy reads. So that was something we worked on. And also emphasising the social norms models. We used lots of case studies, but still people felt that they needed more role models, people like me, people that have similar motivations and barriers and similar experiences in quitting. They wanted to see that. And we know that copy and paste is really important in behaviour change. People see it and they feel that they can achieve it. In terms of accessible services, people wanted to understand the variety of options available and also the times and dates. Again, we do this in spades, but we clearly weren't reaching people across the board. Next slide, please. So in terms of increasing readiness to quit, people felt that they needed, again, for it to be really explicit that the service was non-judgmental. There's a real fear of stigma and judgment, and they wanted to understand that the service would be friendly if they were approaching it. They also wanted to have harm reduction approaches within there. So vapes as part of the core service, and also not just the abrupt model, cutting down to quit was going to be really important. And getting ready to quit. Stress management, this is core business for stop smoking services, but it wasn't something that people were aware of. And again, it came across strongly around the role models. Next slide, please. So in terms of maximising reach and engagement, I reviewed the evidence base, I reviewed the National Centre guidance for smoking cessation training, and also NICE guidance, alongside the insight work that we'd done. And redesigned the service to include more harm reduction approaches. So we had got a cut down to quit service option, which was 6 weeks, where people could come and get support for 6 weeks. Cutting down, they could just have a go. If they wanted to set a quit date, they could go on and have a further 12 weeks of support. We also included 12 weeks of free vapes, nicotine replacement therapy, and varenicline. There was no prescription charge. Again, given the cost of living crisis, that was really important. Strengthened referral pathways with partners. There'd been some distance because it had been COVID for over 2 years, particularly with primary care and the voluntary sector partners in terms of referrals, and there'd been a lot of signposting, so it was really important. And also working with people who were working with people with mental health and disabilities was really important, having more direct referral processes. And we delivered outreach into community settings following what was the vaccination model and linking with primary care networks, and also paying the voluntary sector for room hire to help build the sector again was really important. We contracted with a local vape company called Mirage. They had 18 shops in the most deprived communities in the city. That was really important in terms of accessibility. And also we had reciprocal referrals from them and training so that we could make sure we were maximising impact there. Reasonable adjustments. This was really important. We've always offered reasonable adjustments, but it wasn't explicit. So we built that into triage to make sure that it was part of the conversation at the very early point. Next slide, please. So this is us. We moved to a model from an abrupt model to quit, switch, cut down to quit. And ultimately, you still get 12 weeks of behavioural support with either nicotine replacement therapy, varenicline or Zyban, or you can use a vape for 12 weeks, or you can use the cut down to quit programme. Next slide, please. In terms of partnership working, I mentioned that we worked with a range of partners. There was over 50 partners, and I've listed a variety of those here. And it was absolutely instrumental that we were working across the board with housing, with substance misuse services, with mind, talking therapies, SMI health checks. And we also took it as a priority to the physical and mental health group, and that became one of their key objectives in terms of reducing smoking prevalence, and that's still in there now, 4 years on. We conducted a roadshow with primary care networks, and this added alongside the service manager, and that was really effective in re-engaging GPs and reminding them about referring, not signposting. And the feedback loop was really important to all partners around referrals and outcomes, and thank you emails and meetings. It really went a long way. We relaunched the service with a comms campaign and radio advert and lots of city centre engagement, which you just saw on the previous slide. Next slide, please. And I'm delighted to tell you, after the first full year, 95% of people setting a quit date with the service were from all of our priority groups, all 14 priority groups. And we saw the number of people with a mental health condition increase from 600 people coming into the service to 1,147. So it was phenomenal. The service model was working. It was attractive to the people and the priority groups that we needed to get into the service. This now in 2026 is around 1,300 people with mental health conditions that are coming through the service. And we've increased by 1%. We're at 96% of quit dates set from priority groups, which is fantastic to see. Next slide, please. In terms of the cut down to quit model, we had around just short of 200 people who came onto that programme. I think it's really important when we look at this, in terms of the outcomes at 12 weeks, it was 34 people that achieved that 12-week outcome. But these are people that would have never come to the service without this option. So it's really important. The numbers can feel small, but they're absolutely critical. And I often think that's a classroom full of children. You know, it's huge numbers coming through if you think about it in the real human aspect. 49% of those accessing the cut down to quit service had a mental health condition as well, so it showed it was really important for that group, and over half were from IMD deciles 1 to 3. Next slide, please.
Just a minute left. Thank you, Sarah.
Okay. So in terms of the outcomes, what I'm delighted to tell you is that we actually saw an increase of 67% increase in referrals, 45% increase in quit date set, and 64% in 4-week set, and also 83% increase in 12-week set. Next slide, please. Rachel, can we go on to the next slide? In fact, next one again. I'll just end on, there's not going to be time to cover all of it. So as part of the South Yorkshire Tobacco Control Collaborative, we built on the insight work that we'd done previously and developed the first smoking and mental health campaign that addressed smoking and stress. And this was looking at myth busting around all of what we heard around the perceptions of how people believe that smoking helps reduce mental health stress. And we had 2 phases within this, one that just focused on mental health, the benefits to mental health per se, and then the second was around smoking and men's mental health. And with this campaign, we produced a range of resources. There was a TV advert, a radio advert, we had professional resources, and we also had a range of public resources, social media content. And this campaign had significant reach in terms of engagement. And also we did lots of cases and lived experience work, and people, again, the stats are in here, so I need to stop there because I've reached my minute, but you can see it when we circulate the presentation. And we worked with a range of partners across the country, as well as Dr. Debbie Robson and Professor Anne McNeil, to develop the campaign to ensure the messaging resonated with local people. And they've also conducted some research to test that messaging, and of that sample size, of which there's around 1,500 people, a third of that sample really enjoyed that messaging and felt that it resonated and it would help them in seeking support and motivating them to quit. Thanks.
Wow, that was fantastic. And again, just the enthusiasm and passion really comes through, Sarah. So thank you very much for that. Just to emphasize how important it is to get real lived experience insight into what are people thinking, what are the barriers, and then shaping a comms campaigns to reach that population, and also then building that into a strategic approach with health system partners. Fantastic. And I'm sure, you know, there is this shift now, isn't there, with the public health grant and tobacco control being consolidated over a 3-year period for local authorities to make these kind of longer term strategic pushes on smoking cessation. And you've shown the way of how to do that. So thank you. We've got 2 more contributors, and then we'll open up for questions. We wanted to have a couple of practical examples of the integration of smoking cessation into different settings. So Dr. Gemma Taylor has led the way at the University of Bristol at looking at how to incorporate smoking cessation into talking therapies. So with no further ado, Gemma, I'll give the floor to you. Thank you.
Thanks, Mark. Okay, so I'm Gemma Taylor. I work at the University of Bristol and the University of Bath, confusingly. I've been working in this field for a number of years now, and I'll talk to you today about some systematic reviews that have some really strong evidence that have been incorporated in public health campaigns, for example, Sarah's that she was talking about earlier. And then also 2 randomized control trials that we've wrapped up recently in Talking therapies. Next slide, please. These are my disclosures and funding. Next slide, please. So I'll talk to you about the link between smoking cessation and mental health, and I'll talk to you about the 2 trials. And just a bit of precursor, the trials were of the same intervention, but one intervention was face-to-face. The other intervention is online. And if you're interested, the online intervention, which I'll tell you about, is available for commissioning and procurement from the provider SilverCloud. We're just wrapping up a licensing agreement now. Next slide, please. So I've added in a QR code, so if you want access to the papers. So we published a highly influential review over a decade ago now in the British Medical Journal, and we found that stopping smoking improves mental health. And then we updated the evidence in the format of a Cochrane review, and that was published a couple of years ago now. Next slide, please. And the main findings from this review is that stopping smoking offers mental health benefits equal to taking antidepressants. And I can answer any questions about how we came to that conclusion, but that was the take-home message. So stopping smoking offers significant mental health benefits. Next slide, please. And off the back of that finding, I thought, well, if stopping smoking offers benefits this large, why aren't we offering smoking cessation as part of routine care? If you know, there are people entering services who are depressed and anxious, could we not optimize their mental health treatment by helping them to stop smoking and improve their PHQ and GAD scores? Next slide, please. So we ran 2 trials. I think everyone here knows what talking therapies, or previously known as IAPT, is. If you don't, I think everyone here does, but if you don't, they receive over 1 million referrals each year for anxiety and depression-based illnesses, and they offer evidence-based therapies like cognitive behavioral therapy. Next slide. So the first trial was a face-to-face intervention, and we conducted it over 4 regions in the UK, including 5 IAPT services. We included adults that met criteria to enter the services who were regular smokers. And it was a pragmatic trial, so if people had other comorbidities that were permitted in talking therapies, we included them in the trial. And the treatment consisted of integrated smoking cessation treatment, and this was nested alongside the usual care. So if a client was going in for an hour session of CBT for their depression symptoms, the therapist would include the cognitive behavioral therapy for smoking cessation in that same session. And the control group was usual care with delayed signposting to smoking services. This was a feasibility study, so our primary outcome was not smoking cessation. It was whether or not they completed IAPT treatment. This was because if we're offering people smoking cessation service while they're receiving therapy, and as a result of us offering them the smoking cessation treatment, they leave the service, well, then commissioners aren't ever going to permit the smoking cessation intervention within their service, because it's undermining the primary treatment goals. Next slide. Please. Thank you. So I'm not expecting you to read everything on this, but this is to show some parts of the intervention. So it's extremely formulaic. This is based off of the National Centre for Smoking Cessation Training. Their checklist for which behavior change components need to be offered. It looks like a lot, but a lot of these actually only take a few seconds, and not everything is offered at each appointment. And the key one was that we spoke about beliefs around smoking and mental health and how this was impacting on mental health. Next slide, please. And we based this discussion around a standard cognitive behavioral therapy model. This is also known as a hot cross bun for anyone who's delivered CBT before. And in this model, your thoughts, your emotions, physical sensations, and behavior are all related. And in this example, this is an anxiety cycle in smoking, and the trigger would be an anxiety-provoking event. And someone might think, oh, I'm really stressed out. I need to have a cigarette. I'll feel better. And they feel nervous. They feel anxious. They feel the physical sensation to smoke. So they feel restless. They feel tense. And then they smoke. And then they have that temporary relief. But what we know is that the half-life of nicotine and other constituents in tobacco lasts 20 minutes. And after that 20 minutes, those constituents start depleting in the blood and they're back in this cycle. So it's an unhelpful coping strategy to deal with stress and anxiety. And this is what we teach in therapy. This fits exactly into what the CBT therapists deliver for other unhelpful coping mechanisms. Next slide, please. And just to say, I'm sure these slides will be sent out, but I've published a practical guide as well. It was actually on the last slide, but it was a practical guide for clinicians. So anyone who's working as a therapist or who's client-focused, client-based, and it gives practical tips and tools about how to deliver this exact same intervention. So in terms of stakeholder perspectives, we did lots and lots and lots of qualitative work. There's a few papers published there, but in general, what we found was that that the PWP's therapists noted that there was a reciprocal impact of smoking cessation and mental health treatment. So such that when a client stopped smoking, what that actually did is that it gave them the confidence boost to break some of their other depression maintaining behaviors. So that boost in confidence from stopping smoking, then it's I guess like a standard behavioral activation approach. So if you change one behavior that's maintaining your ill health, then that kickstarts other healthy behaviors to start happening. The PWPs, the smoking, the service managers, they thought that smoking cessation treatment was a natural fit into IAPT. Talking therapies. They're anyone who works in talking therapies, you guys are a true believer in there's no mental health without physical health, and smoking is obviously going to damage your entire body, including your brain, causing inflammation everywhere. And then also the clients really appreciated the therapist-client alliance, which is quite different to what could be offered in other services, because the therapist knows the patient knows that the stresses that they experience in their life, which Debbie picked up on earlier, which can really potentially undermine a quit attempt. The therapist was able to bring those other stressors back to the smoking cessation situation and other factors that are contributing towards that person's journey. Next slide, please.
That's just one more minute. Thank you very much, Gemma. Okay,
thanks. So these are the results from 6 months from the main trial, and what we found is that the treatment did not impact on IAPT completion status. So offering smoking didn't undermine treatment completion, and we also did see some positive effects on stop smoking. We didn't see any impact on mental health, but we didn't see any worsening either. So in the interest of time, all of this information is fully available and published, and we now have the smoking app available for commissioning through SilverCloud. So if you're working in a service and you need help implementing this, please do get in touch. We're seeing, I mean, it's research, it's the health sector, so things are slow, but I think we can really expedite this. This fits so well, and we know these treatments are cost effective as well. So please do get in touch. Thank you, Mark. Thank you, everyone.
Yeah, that's fantastic. Thank you very much, Gemma. And as I have a family interest, my wife is a therapist, and I think it's just such an important, incredible interface, and to know that it strengthens the therapeutic alliance and its expression of the whole person. It's really important evidence that you've been collating. So really key for do put your questions in the chat for Gemma and how we can replicate and scale that approach. So we'll give you one more really fantastic speaker. Oliver Holdsworth is is the research and evaluation lead at Cambridgeshire, Peterborough and South Lincolnshire Mind. Really fantastic to have Oliver with us and to talk us through how they, from a voluntary sector perspective, are integrating smoking cessation within their work and their services at Mind. So thank you very much for joining us, Oliver. Really delighted to have you with us. We can't hear you. Are you?
Oh, did the camera, not the microphone.
Great.
Here we go. Thank you, Mark. As he said, I'm joining from CPSL Mind, the local Mind branch here. At CPSL, we have a range of different services supporting individuals with mental health challenges around employment, around perinatal, when you're being discharged from hospital, connecting to the community. We run community cafes. But our newest service, we started in October of 2025, is the smoking specialist support service. So briefly, the structure is we have 2 part-time advisors. We have 2 pathways that an individual can go on, ready to quit for 12 weeks and cut down to stop at 20 weeks. We can visit people in homes or wherever they would like, wherever works best for them. So today I'll just do a quick whistle stop tour of how we got set up. And also I know, Mark, you particularly requested if we had any barriers or challenges. So I'll make sure to include those as well. So next slide. So I think we all know this work here, but this is really how we got, part of the reason we got started, this work from Gilbody et al. 2019, showing the bespoke service for individuals with severe mental illnesses seemed to be more effective than standard treatment. Next slide. Next, thank you. And then from this, we get the nice recommendations that additional support seems to be warranted with those with SMI and perhaps those with more general mental health conditions, but there's a bit of a gap here. Next slide. So to sort of, before we even set up and thinking about that, what extra research may be needed, I helped to quite a lot of qualitative research. First of all, with recruiting co-designers, so individuals who had lived experience of mental health conditions and smoking, whether or not they were ex-smokers or current smokers. And they then interviewed 15 other individuals between them who also had that lived experience. So we had ex-smokers, current smokers, people who had quit for 5 years and then had relapsed. We had people who had been smoking for 30 years. And they did a range of interviews from 15 to 30 minutes, 50 minutes to an hour, sorry. Next. We also had I also conducted interviews with professionals in the health and social care sectors. So lots of people are actually in this call, which is nice. Academics, people working in the NHS, people running other smoking cessation services. Next. And then finally also did a survey with multiple choice and essay style options. The point of all of these bits of research was to try and find out from individuals what they thought worked and didn't work with smoking support. Talked a lot about mental health, talked a lot about smoking, but really the idea was what do we want out of a smoking cessation support service? Next. And from this, sort of 3 themes really emerged, which I hadn't sort of thought about a useful way of breaking down before, but seemed to come from what people were talking about. First theme, before support. So barriers came before you even, before we could even talk to people. So why do some individuals not know about support or are reluctant to use it? Second, next slide, please. Also during support. So why do some individuals seem to disengage from support once been engaged with or not quit for whatever reason? And third theme, after support. So this is a really big one that emerged for me. Lots of people talked about, both with lived experience and also with professionals bringing this up, that although we may see quit rates at 4 weeks and even 12 weeks, the long-term rates aren't so good. So next. So just returning to that 2019 paper from Gilbert et al. Even with this bespoke treatment at 12 months, if we do CO verified, we get about 15%. And that's actually quite a high number when you kind of look at other studies as well for after 12 months. So really wanting not only to help people quit, but also stay quit. So with each of these 3 themes, we came up with different solutions. We invited other professionals. We had a nice big meeting talking about this and tried to come up with some ways to tackle this. I'll sort of go through it as we go. Next slide. How do we do? I have to skip Mary Yates. I'll come back to her later. So let's go again.
No, you're doing fine.
I'm worried about time. No, well, you don't know what's to come, Mark. So, so how do we do? Well, barriers, fine. So before support, we struggled with this area. We really struggled with referrals for the first few months. We had almost none coming from the SMI health checks. So this was meant to be this big source. We knew lots of people were being referred previously. We didn't understand why this had stopped. These checks were coming to an end within our area. So we weren't aware of that before we started. Also, even before they came to the end, we stopped getting referrals. We also just weren't getting as many referrals from other sources as we're hoping from, neither internally from CPSL Mind, from other services, but also from outside of that. However, through increased and sustained engagement with social and health professionals, both internally within our own organization, but also externally across the NHS and other voluntary and community settings, we've seen numbers increase. So next slide, please. So you can see just starting here, these are quite obviously low numbers, but small service. Starting in November, we had 4 referrals. It's not really what we wanted, creeping up as you're going through December, January, February, bit of a dip in March, but April and May now we're looking much better. And also what I'd really like to point out here, which we're really happy with, is the number of referrals you see in the blue, which is, we want to get a large number of referrals. But really, also what's really nice is the numbers engaging, the proportion of that, particularly as you see in April and May, has really increased. So when I say numbers engaged, I mean, we get referred, that's the blue, but we don't even speak to someone. And that's the gap there. So why are we getting referrals and we've seen this big gap between actually being able to even start a session with someone, even start that conversation? You see in January, that was a particularly bad month, 8 referrals, but only 1 are actually engaged. Most of the time, we're unable to contact. We're not able, even after multiple attempts, not able to contact. Sometimes the eligibility criteria not being met. You see that those things improving. I think we've done much more work with professionals who are being giving referrals to make sure they really understand what we're offering, and so the client then who they're referring also understands that. So that's, I think, part of the reason why we're seeing that gap close. But we'll see how we go. Next slide, please. Next. Okay, yeah, so just maybe of interest for people here, location of support, by far and away the most common is the refrain of ET, phone home. People prefer to be seen in their own homes almost all the time, and then that's sort of topped up with phone calls along the way. A lot of our clients are anxious about leaving the home or unable to leave the home for whatever reason. I think even if you are able to leave the home as well, it's just much nicer if you're able for people almost always like us to come to them. Next, products used. Props, again, not a huge surprise here. Most common vape and NRT, a combination of vape and NRT. We're also seeing increasing use of varenicline. So we've always offered this. We've always said it's an option for individuals we support. But I have to admit, I think we grew in confidence quite a lot a couple of months ago in offering this and pushing this. We had some specialist training from Mary Yates, who's really fantastic practitioner and a campaigner. And she was really pushing this for us. We're now much more confident in offering it. We're also much more confident in contacting GPs and have a set letter showing its safety for our clients. And they're now more confident in prescribing that. Because, of course, I'm sure you're aware, we can't prescribe varenicline. Next. This may also be of interest. So I was just of the clients we've had so far, the average time, and the average, by the way, this is both the mean and the medium, if you're kind of wondering, from when we first see someone to when they first begin that successful 4-week quit. So not when they end it, when they first begin it, is 6 weeks. So it takes 6 weeks for the relationship on average before we begin that successful 4-week quit. That is just the average. Some people, the lowest was 2 days, which was very good, and the longest was 16 weeks. So it can take a time, but that's sort of the average we see. Next.
Jeff, a minute left. Thanks a lot.
Thank you very much. So as part of what I've been doing as well is I ring individuals for short interviews, 20 minutes to half an hour as we're going along. I offer a £10 incentive to have a chat with me, and I'm really just trying to understand what's going on with them and like how they're finding the service. I picked this quote out because I think it represents quite a lot of what we're getting right, but also in the times where we haven't got it right, what's going wrong. So this is an individual who started a 4-week quit and then unfortunately relapsed and is now 16 weeks quit free. It's a really good quote. I think it's really showing a lot of what we're trying to do. This individual, they suffered a bereavement, they relapsed. They were really worried about that, about relapsing, and they were really worried about the judgment they may face. They were delighted to find that judgment wasn't there. That's at the beginning part of the quote. The last bit is talking about the support, that if there's anything you needed, there is a number and you can speak to someone. Next slide, please. Next, thank you. I'm really, oh no, so if you go back, sorry, yeah, sorry. Thanks, Rachel. There we go. I really wanted to highlight these two things because that non-judgmental thing and the person-centered responsive support is both the thing that people most often bring up as they liking about the service. It's also the things that people bring up most often of not liking other services that they've had or not, or worried about that. And it's also to the times when we're not, we don't get the positive feedback, which is, it's very hard to get someone to give negative feedback. We've never got lower than a 4 on satisfaction out of 5, even when someone leaves the service. But to the extent we do, it's perhaps we didn't take enough time. We weren't quite there on the level or the pace they wanted. Next and final slide. Okay, so going back to Mary Yates, and this is something that's really kind of like the message that I'm taking so far from what we're doing. As Mary Yates says, it's really about understanding that the journey takes time. And we don't have to rush it. It's worthwhile. Next. So the time the advisor is able to give to the individual. This is an elusive thing, time. We're lucky to be able to have it in our service, and I know others don't, but it's so important. The time for gentle starts, so to build up slowly, to cut down slowly. Also the time to be able to have bumpy starts where people relapse and that's okay, and it's not a problem. The time for quick responses, so the time that our advisors are able to give, so if someone has something doesn't work, if they're not able to get their medication, that we can work with pharmacies, GPs to get that for them. The time also for long relationships, to be able to support an individual for several months, not just a few weeks. Also, very importantly, the time to build relationships with medical and social professionals. Both going to lots of events, but really sustaining those relationships. One of the things that we really learned is that we not only have to win the trust and build that relationship with the clients we're working with, but also practitioners who may be worried about referring because they're worried about their client dealing with something else and they don't also want them to stop smoking. So we have to build that trust with them that we are going to support them in a way that's helpful for them and doesn't interfere with other things. Okay, thank you.
Yeah, another fantastic. Thank you so much, Oliver, and for that. It's been very practical, very applied, and some of the themes around non-judgmental and that person-centered approach and actually people feeling valued was echoed in what Dr. Gemma Taylor was talking about as well. So thank you very much. If we can give a virtual applause to all of our contributors who I think you can see from a whole range from the public sector, for the voluntary sector, from academia, giving us some real food for thought. Yeah, we're happy to come to. We've got maybe just thank you. Let's give a virtual round of applause for those. And maybe I can just kick off the questions. We've got a number of questions around some specific practical people wanting advice, wanting links to particular individuals or training methodologies, resources. So if we can follow those up, that would be really fantastic. If I can just come to the panel with this opening question, which is, if you had to give advice for people working in service, local authority, NHS, how to promote, how to prioritize smoking cessation and integrate it within a campaign or new resource or new service, what would your advice be? So I'm looking for some quick fire responses. What's been the key to in getting initiatives up off the ground or persuading people to support this cause? So just some comments from some of our contributors. Who wants to share their? Yeah, go on, Sarah.
I think it really is about the variety of options, and it's not just about having the abrupt model in play that we've always had in stop smoking services. It's about having harm reduction approaches, so cut down to quit. It's about giving people the opportunity to just try it out and test it, as well as having those formal structured approaches. And it's definitely about having vapes as part of the option. So it's a range of options. And I think the other thing is really making it as easy as possible. So meeting people where they are at and looking at reasonable adjustments. So, and it's just simply saying, how can we make it as easy as possible for you to attend this service? And going through that conversation. I think those are the critical parts that we found for Sheffield.
Yeah, that's fantastic. Can we see that? Gemma?
I think one of the biggest things is that you can just talk about the mental health benefits of quitting. It is so commonly believed, the general population, people using services, clinicians, it's still believed that smoking benefits mental health, and it's just not true. Even so scientifically, we've shown that. I've got some students right now looking at how smoking causes inflammation through the whole body, but how that mediates worse mental health. But commonsensically, how can smoking destroy the entire body but benefit the brain? Mm-hmm. It just doesn't make sense. So I think just saying that is quite simply is quite powerful.
And I want to come back to that because I can hear, that's even clinicians are not confident with that evidence, and I think it is the starting point in it. Because if that doesn't happen, then the rest doesn't flow. Sarah.
So I agree. We're doing some work with clinicians. It's really, really important. It's something we're having to do in the Southeast as well. I would say as well, obviously we had a lot of the resources and the scientific background and the papers, and we had a whole pack that everybody could receive that included Gemma's papers that she's referred to. So that was really useful. But I think the biggest, when we were talking to people, particularly on the roadshow, the biggest thing that really made people stop and listen was the fact that a lot of the physical health issues are side effects. So you smoke because it helps your stress, and the side effects of smoking are these physical symptoms. And some people are thinking, well, you know what, I'd rather get through my day and worry about some of the health issues I might have later down the line. When we were saying to people, but the very reason why you're smoking is a lie that your brain is convincing you, that was what was really powerful. So it was the fact that there are other benefits from quitting smoking for mental health in the same way as physical health, but it was that fact that we could challenge but the very reason that you're smoking is actually not true. It's actually the opposite. You're smoking because you believe it helps your mental health, but actually we can let us just show you that it's the absolute opposite. And that was what we found was really, really powerful when we were talking to people.
Yeah, and let's because there's a few comments in the chat there about a refrain that I hear a lot, which is this, people, especially in psychiatric wards, are saying that smoking is the last refuge, the last support, and clinicians are sometimes and so there's I think there's a couple of comments there. One from David saying, should we listen more, acutely to people experiencing mental health problems and understand so that we're hearing the reason why people are smoking, and then just ensuring that our approach, I think Joe said, is rooted in empathy and compassion. And how do we balance that with challenging the false beliefs? Can you coexist both compassion with the assertion of the busting the myth busting? So I know we've only got a couple of minutes, but I think this is so common for so many people that it's actually good to hear some approaches to that. Sarah.
I think one of the really important things is any campaigns that we run must have an element around myth busting around mental health as well as physical health. We must weave it into our regional campaigns. It's always difficult on messaging, but we can do it. And I think nationally, this is something that we're pushing for as a regional comms group, that we make sure that it is visible within mental health campaigns at a national level as well. Because if we don't do that on a continuous basis, it doesn't have the traction that it needs on a regular basis. So I just think that's really important at all levels, both local, regional and national.
Absolutely. And that framing that Darren's put in the chat around shifting the idea around smoking being a lifestyle choice to an addiction is something that the Chief Medical Officer, Chris Whitty, has been so passionate about. Is like a starting base as well. So thank you very much for that. Oliver.
Thank you. Yeah, just on the, I think it was sort of on the point of empathy and compassion, but also the fact that it sort of seems to help with your mental health on the short term, and how do you sort of approach that? I think we would share any information that, long term this is going to help, but really, of course, you have to meet someone where they are right at that time, and it does seem to help at the moment on the short term. So there's two things I would say about that. Look, first of all, in the advisors and the sessions, they spend a lot of time, sometimes most of the time, I think, not talking about smoking at all, talking about something else that's going not happening well in their lives. Which of course really helps, but then and also builds trust and allows them to talk about smoking later, I think. We can signpost a lot for other things, and we can also just be a sounding board, which is really obviously helpful for people. Also, getting started on NRTs helps, right? So it's a huge thing to give up smoking and getting rid of that NRT. Say like, I can't, this is really helping with my mental health, and to go from 0 to 100 would be incredibly that would be a big thing. So what you can do is you can keep smoking, but also with the NRT, and then gradually come off the smoking and bring up the NRT. So the mental health, that kind of nicotine replacement, is still being looked after along the way. But yes, one empathy and compassion. Yeah, I think that's pretty big.
Yeah, thank you. That's really helpful and really insightful and very practical. I will close the session here. Thank you so much for everybody. If we could just thank Oliver and Gemma and the two Sarahs and Rachel, and also Dr. Debbie Robson as well for your contribution and your time today. It's been fantastic. Please consider how you can take this message of reaching people with common mental health disorders and understanding where the data is and understanding what support they can have to help them quit smoking. It's going to be a massive part of our journey towards a smoke-free generation, and we can't leave people with mental health conditions behind. So thank you very much, everyone, and have a good rest of the day and weekend when it comes.
Thanks very much.